I'm the only one here today. I was in a rush. We've had a bunch of problems. Basically, this is for Med-Surg Exam 5. It's your boy Tyler. I'm the only one here, so I'm just going to explain it to myself and to whoever else happens to come across this. It's also for Kayla, because Kayla's not here. Otherwise, I'd have somebody to hold the camera, and then I could be funny in front of the camera. But thank God, because I haven't shaved. First thing we're talking about is disseminated intravascular coagulation, otherwise known as DIC. It's important to know that it's not a disease, but an underlying disorder. Now, basically what's going on with this is their body's clotting and bleeding out like crazy. It's just weird, hard to explain. She covered it a little bit, but this is the most important stuff. Triggers, sepsis, shock, trauma. Shock's on here like 3 times. It's very important. As you can tell, I'm rushed. Cancer, abruptoplacentia, toxins, allergic reactions, stroke, heat stroke, burns, all that stuff. And altered homeostasis causes massive clotting in the microcirculation, but the clotting factors are being consumed, so that means bleeding. So this is an oxymoron. Heck yeah, there's gonna be better videos on this, but this is just showing what I'm going over for class. Now, the treatment for DIC is one, trying to figure out what the heck the underlying cause is. That's the #1 treatment for almost anything in nursing. But the other thing we're gonna try to do is correct the ischemia, which is the tissue death that's coming from this clotting in the microcirculation. And that can lead to a bunch of complications, especially if it's going to the kidney or the liver. It could cause cirrhosis probably. You're also gonna wanna maintain that BP and replace the coagulation factors. One thing we may be giving is heparin or low molecular weight heparin. Another thing I found, which was in the book, is we're going to administer O2. For DIC, we're gonna administer O2, replace fluid, collect electrolyte imbalance, and give vasopressors. Vasopressors, a side effect of those is MI signs and symptoms, so we need to be aware of those. So if they're having a hemorrhage with DIC, they're bleeding out like crazy, what are you gonna do? You're gonna give them freaking vasopressors and platelets. Now that's the basics for what you need to know for DIC, probably, and I'm gonna make another video more than likely on this after I figure out what the heck it is. Next we got phenochrome. I wrote it weird because I can't pronounce it as it is, so I might as well make it harder for myself. Now this one I can explain better. It's a rare tumor that causes excessive catecholamines. What are catecholamines? They make epinephrine and norepinephrine. They do stuff with them. And basically epinephrine and norepinephrine, they're the hormones that regulate blood pressure and heart rate. Now, if you have phenochrome, you're gonna have increased glucose, which is glucosuria, hypertension, tachycardia, headache, increased metabolic rate, diaphoresis, abdominal and chest pains. Now, I came up with a cool way to remember this, and if you know film photography, which you know I love film photography, pheochromocytoma, that chromo, we're talking about Kodachrome, Ectochrome, Fujichrome, which is also known as Fujivelva. They all have that chrome in there because they are awesome. Best films ever made that I'll never get to use. Now here's the thing, okay? Here's the thing. The people that still have these films, I call them film hoarders. They keep it in their closet. All of them have diabetes, so increased glucose. If you're watching this and you're one of those people, I'm sorry, but this is how I'm getting an A on this freaking test. The next thing that you're gonna see is hypertension or tachycardia. If I got a hold of one of these films, the first thing it'd do is my heart would start beating through my chest. Like, oh my gosh, I got a freaking Velvachrome. I get to shoot some film that's amazing. And then hypertension just because I'm hyper. Also, headache. You know how much of a headache it is to find any of these chrome films, especially Fuji, or no, Fuji, no, it's Kodak Elite Chrome 200. It's such a headache to get. You're gonna have an increased metabolic rate because if you see it, you're gonna run for that chrome film, and diaphoresis because you're not gonna be able to breathe after you get to it. You're gonna have abdominal and chest pains from it because it's worth having a heart attack for. Diagnosis for pheochromocytoma is urine and plasma levels of the catecholamines. See those catecholamines? The cats. So you're gonna check your urine and your blood for cats. And that's how you're gonna know if you have this pheochromocytoma. 24-hour urine, x-rays, and that's gonna be used to confirm the tumor. Another thing about this pheochromocytoma is that it's a film. What did they use before digital cameras whenever they wanted to get an x-ray? They used x-ray film, I think. Now, the biggest thing with this pheochromocytoma, and I'm gonna make you say this, is the 5 H's. Take a look at it real quick. And we're gonna spit it out. 1 is freaking trains. 2 is, 3 is, 4 is, and 5 is. And if you didn't know them, or you're driving or whatever, 1's hypertension, 2 is headache, 3 is hyperhidrosis, 4 is hypermetabolism, and 5 is hyperglycemia. Now that's the manifestations used to diagnose this, as well as the urine output, 24-hour urine, x-rays, all that stuff. Medications for pheochromocytoma is gonna be alpha blockers, beta blockers, and vasos to maintain BP, but we're gonna get to that later. The medications, alpha blockers. Now think about it. There's not an alpha chrome, but I'm sure there is an alpha chrome. But alpha blockers, we're gonna have Cardura, also called doxazosin. Professor mentioned this one a bunch in class. Minipress, also called prazosin, and Hitrin, which is cetrazocin or terazocin. I probably just put this here because it was going to be in parentheses, then I forgot to do it. So terazocin. And what this terazocin, this Hitrin does, or probably all these, is actually, yeah, it is all these. They relax the muscles and keep the small blood vessels open, which is a problem you have in pheochromocytoma. Now, what time is it? And look at that train, guys. Do you see that train? Freaking ABAC for you, trying to film a video here to study with. Beta blockers, bro, because your heart rate's through the roof. You got that tachycardia and hypertension with pheochromocytoma because you found that Fujichrome 200 and you were absolutely losing your crap. You need a beta blocker like atenolol, metoprolol, protanolol, or propanol. And basically it's gonna be a heart rate that slows down the heart and makes a more forceful contraction. Think about it, it's beating too fast. You know, you're not really getting anywhere with it. It's not pushing any water, but then you slow it down, the heart's beating, it's gonna be able to push that fluid. Now, TX for pheochromocytoma is vaso to maintain blood pressure, which is the same as that vasopressor over there. They have a low blood pressure, gonna give them that vasopressor, and it's gonna press that heart rate up. Now, if you see oliguria with pheochromocytoma, that means they're in shock, so you gotta do something about that. Both glands can be removed. Now, oh wait, I did this wrong. This is post-op for adrenalectomy. I should have wrote it better. So same thing, post-op adrenalectomy, vasoconstrictors mean blood pressure, oliguria means shock. But if they take out both glands, they're gonna be on corticosteroids for life because their body cannot produce it anymore. Now that we've gone over DIC and pheochromocytoma, the real star of the show. I'm telling you, I did this in like 45 minutes and it's absolutely like, you can see my handwriting's kind of neat over there. Then over here, I was just like, screw it, I'm writing it big. All the freaking all these expo markers are done. You know what the deal is. We're 8 minutes, 36, 38, 39 seconds into it. We're getting done with this. Diabetes Insipitus, you got me, is written cool so that you remember what it looks like. You got me? Now, basically, this is the posterior pituitary not working right. We're having a decrease in ADH, which is vasopressin, which means that you have the inability to conserve water. This could be related to a head injury, a surgery, whatever. You just screwed up your head. Now, this was in our notes. I don't think we need to know this, but just in case, because I am making a freaking 90 on this test, is neurogenic DI. That's decreased antidiuretic hormone. So think neurogenic. I'm at 8% battery. I got to hurry. Antidiuretic. Nephrogenic is insensitive to ADH. So nephro's a butthole, neuro's in the brain, and then we got dysogenic is an increased intake of liquids. They're just drinking too much with dipsogenic, and it kind of sounds like what's that word? I wrote it down over here. It's a sign and symptom. Dang it. Because I'm going straight into this. I had no practice or nothing. It's like polydipsia. That's what I'm thinking of. They have gestational. That just means they get it when they're pregnant. Now, diabetes insipidus, she just had a slide like this where it said polyphase. Oh, there's what I was looking for. Polydipsia, polyuria, risk factors for dehydration. Like, they're at risk for it big time because that's what this is. They're just peeing out like crazy. I was going to draw a waterfall, but I didn't have time. Serum urine osmo is the #1 test for this. And we're going to have a low osmo for the urine, and it's going to be high for the plasma, but we're going to get to that later. If it's drug related, it's going to be this ethanol and phenochrome. That's going to decrease that ADH secretion. If it's lithium and democlocycline or whatever, that's going to be ADH. Something. Signs and symptoms of diabetes insipidus. Oh, it's going to decrease ADH action in the kidney. I'm stupid. I'm not stupid. I need to be positive. I'm a smart person, and I'm going to do good on this test. Diabetes insipidus, signs and symptoms. Same thing for dehydration. Decrease in skin turgor, dry skin, dry mucous membranes, dehydration. What's my battery at? 7%. We're going to have an increase in plasma osmolarity. Normal plasma osmolarity is over 295. So 8675309, 8 plasma osmo 295. Yeah, on the spot, bro. I got this. I'm simple nursing 2.0. Urine osmo under 500. It's under 500. Signs and symptoms of shock. We're going to have an increased blood pressure, increased pulse rate, and increased respirations. Now, this is all for diabetes insipidus. So we're going to see they're going to have a slower heart rate. No, a lower blood pressure, but an increased pulse rate and an increased respiratory rate. We're going to see weight loss, muscle weakness, dizziness, signs and symptoms of dehydration, which is basically the same as shock. Hypernatremia, that's too much sodium in the body. Urine-specific gravity is going to be low. That looks so trippy. Is it blurry for you guys too or just me? Now, it's going to be 1.001 through 1.005, and normal, without looking, is 1.01 through 1.025. Yo, boy is... I got it. Okay, cool. We good. I thought I got it wrong for a second. I might have. Who knows? DI or DX procedures, we're going to have fluid deprivation tests. We're not going to give them any fluid for 4 to 18 hours, right? We might give them a little bit of hard candy, though, because this thing sucks. While we're doing that, we're going to be checking the vital signs and the urine-specific gravity hourly. Got me? We don't want them to die, so we need to make sure that we check those vital signs and that urine-specific gravity to see if it's actually what they have. Now, it's a positive, this DIDX procedure, where they test to see if they have diabetes insipidus. It's positive the urine-specific gravity stays low if the patient continues to excrete large volumes of fluid, if the serum osmolarity increases, if the urine osmolarity decreases, or if the serum sodium increases. Now, here's what's cool is you can use this for everything else, because if you want to see how effective the medication is, it's the opposite of this. So if you are given the medications, they're feeling better, this specific gravity of the urine, right, will start to increase. The fluid is going to become more dilute. The patient will continue to excrete lower volumes of fluid. The serum osmolarity will decrease in the blood because you'll have more fluid in the body, and the urine osmolarity will increase because they're going to have more crap in there. Serum sodium will decrease because it's going to be more diluted. And hard candy, you just give it to them because it's awesome. What's my battery at? 5%. Let's see if we can do this. So, treatment for diabetes insipidus. It's about time. We are at the end in 13 minutes, 49 seconds with 5% of my battery remaining. Oh my goodness, this is so exciting, and I'm wasting time. We give them nasal sprays, that DiiPad or the Lipressin. Lipressin for depression. Oh wait, no, diabetes insipidus. Now we give them the DDAVP. That's the demopressin. Apparently it's $2,000 a year or gram or something. I don't know. And you administer it 2 times daily because that's just how you do it. Now, you might have side effects like chest tightness, ulceration of the mucous membranes, allergies to it. If they can't breathe though, you give it to them sub-Q because this is a nasal spray. So ulceration of the mucous membranes is common. It can happen. That's why we want to give it to them sub-Q. We're going to administer fluids, PO and IV, for these patients because they're going to be peeing all that fluid out as fast as they can with diabetes insipidus. I'm going to start calling it diabetes insipidus. Now, aqueous pitressin IV or sub-Q. That's going to help them hold on to fluid probably, or I don't know, short-acting ADH, that would be good for somebody with transient DI, which is not in the list that we covered. Dang it, professor. Observe for water intoxication for all of these agents, because that might happen. They might get fluid volume overload. TX continue. We're going to give them fluids. I don't care if it's IV. I don't care if it's PO. We're going to get water in them. We're going to give them IV protressin or pitressin, sub-Q, and DDVAP. How are we going to check the effectiveness? Like I said earlier, but over here in blue, we're going to see a decreased urine output. Urine-specific gravity will increase. IV fluid is a priority in the planning stage to correct fluid something. What am I at? 4%? I can waste time on this. Concentration. Oh, to correct fluid imbalances. That should be an I. There should be a dot there. Now, DI nursing interventions. We're at the very end, guys. We're at 15 minutes, 47 seconds. We're going to give them chloropromide. What does that do? It stimulates ADH. That's chloropromide for diabetes insipidus. Insipitus. What else is it going to do? This chloropromide. It's going to augment the renotubular response to ADH. What does that mean? I don't know, but it's good for them. Now we're going to give them thiazide diuretics and sodium restrictions, because they're going to be peeing out all the water, but not any of the sodium. So we need to give them, we need to make sure they don't get sodium, because they're going to go hypernatremic over there. Now, intake and output and daily weights are how we're going to monitor the effectiveness of our interventions. That intake and output, it should start to level out, because they're going to be putting out way more than they're putting in at first. But eventually it should start leveling out to be about the same. Next, we're going to do daily weights, because an increase in weight would be a positive thing for these patients. Normally that's a negative thing, but for them it's a positive. We would also check urine-specific gravity, because it is low. So if it's between 1.001 to 1.005, that's low, but we've done our interventions. So we should see it go up to 1.01 to 1.025. Now, another thing she said was they must wear a med alert or ID bracelet, and thiazide diuretics will be needed. Now, I am out of here. I'm freaking tired. This is stupid. Later, skaters. That was fun.